Accelerated idioventricular rhythm AIVR with regular retrograde P waves. Retrograde P waves are seen just after the QRS in lead 2 and lead 3. The P waves are not that evident in lead 1. The retrograde atrial activation will result in regular cannon waves in the jugular venous pulse. Even though the QRS complex is almost 120 milliseconds in width, at one look it may appear to be not that wide and the AIVR can be missed. In this tracing, the wide QRS is quite evident. The P waves are not very evident, though careful examination will reveal the slight notching of the upstroke of the T waves. The fourth beat shows a P wave with reasonable PR interval and a QRS which is narrower than the initial 3 beats, suggesting that it is a fusion beat. The last beat is preceded by a P wave and has a narrow QRS, indicating that it is a capture beat. This ECG portion shows deep Q with ST elevation seen in V1 to V3, suggesting anterior wall myocardial infarction. Ventricular premature complexes are also seen in bigeminal pattern. This person with anterior wall myocardial infarction developed AIVR, VPC as well as ventricular fibrillation requiring a couple of DC shocks. AIVR is an important reperfusion arrhythmia which usually needs only observation and no active treatment. If it does produce hemodynamic problems, which is quite unlikely due to the medium rates, it can be overridden by accelerating the sinus node with intravenous atropine. The advantage of sinus rhythm is of course the AV synchrony, which is useful in the setting of myocardial infarction with systolic and diastolic dysfunction. Interventricular and intraventricular synchrony will also be better with sinus rhythm. AIVR is also sometimes called slow VT. Thrombolytic therapy used to be an important mode of early treatment of acute myocardial infarction. Though it has been largely superseded by primary angioplasty, thrombolytic therapy may still be useful in certain situations. It is still an important form of treatment in resource-limited locations. Myocardial infarction is usually due to sudden occlusion of a coronary artery by thrombus formation on a pre-existing partial obstruction by an atherosclerotic plaque. Plaque rupture with local thrombus formation is the usual mechanism. Dissolving the thrombus soon after the occurrence of a myocardial infarction can salvage a lot of myocardium from ischemic damage. Myocardial infarction due to sudden coronary occlusion is type 1 as per the universal definition of myocardial infarction. Thrombolytic therapy is most effective when given within the initial 3 hours of onset of symptoms. Beyond that, effectiveness decreases as the clot becomes firmer and more difficult to dissolve by thrombolytic agents. Still, it may be considered as a reasonable option within the first 6 to 12 hours after onset of symptoms. When recurrent chest pain is present, it may be considered even beyond that in rare cases. With the availability of coronary angioplasty, first preference is now given for angioplasty rather than clot dissolving treatment. Coronary angioplasty is the procedure of removing obstructions in coronary artery using balloon catheters introduced through the radial or femoral artery. Balloon catheters are guided to the coronary arteries through larger catheters known as guide catheters under fluoroscopy. Primary angioplasty for acute myocardial infarction has to be done soon after arrival in the hospital for best results. If there is a technical delay, thrombolytic therapy may be considered as an initial treatment to buy time. Thrombolytic therapy cannot be considered for all types of myocardial infarction. Use is limited to a specific type known as ST elevation myocardial infarction with ST segment elevation in the ECG. The reason is that non-ST elevation myocardial infarction is unlikely to have a soft red thrombus suitable for dissolution with thrombolytic therapy. Non-ST elevation myocardial infarction usually has a firmer platelet-rich white thrombus. As thrombolytic therapy has a potential to cause minor or major bleeds, it is avoided in those at risk for significant bleeding. This would include those on anticoagulants and in those who have known bleeding disorders. Thrombolytic therapy is not given in those who had a hemorrhagic stroke. It is also not given in those who had a recent ischemic stroke beyond the window period for stroke thrombolysis. Those who have severe hypertension on presentation needs control of hypertension before initiation of thrombolysis.